Please go ahead. Thank you.
Okay. Thank you, sir, for the kind introduction. I'm going to talk about rivaroxaban today. I have no disclosures to make. This is going to be the structure of my talk. So I'm just going to briefly touch on the coagulation pathway, then give an overview of the various antithrombotic drugs, followed by pharmacokinetics and dynamics of rivaroxaban, its indications, its safety and adverse effects, and how to manage it if there is a bleeding. I'll also touch upon some drug interactions and contraindications, and also a few slides on the benefits over the other anticoagulants and some frequently asked questions. I'm just going to put a few trial summary slides, but I'm not going to talk about it, and then end my talk. We'll be happy to take any questions in the end. What I won't cover is the pediatric patients or management of the pediatric patients. So coming to the coagulation pathways, so we are all very familiar with the coagulation cascade. This is quite important because this will help us to understand the usual clotting tests we send in routine everyday practice. So as we all know, there's an intrinsic pathway and an extrinsic pathway. The extrinsic pathway is predominantly just by one factor, which is factor 7. And the intrinsic factor pathway involves factor 12, factor 9, factor 8, and factor 11. So then there's a common pathway involving factor 10 and factor 2, eventually a fibrinogen and forming the fibrin clot. So the APTT, which we routinely ask for, measures is the reflection of intrinsic pathway, and the PT is the reflection of the extrinsic pathway. So if there's any deficiency of factor 7, then the PT will be prolonged. Any deficiency of any of these factors, the APTT will be prolonged. And of course, if there's any deficiency in any of this common pathway, both APTT and PT will be prolonged. So just coming to the various the drugs, so we have can be broadly classified as antiplatelet drugs, anticoagulants, and thrombolytics. The antiplatelet drugs essentially block the platelet aggregation. Anticoagulants prevents the formation of thrombus, and thrombolytics dissolve the already formed thrombus. So antithrombotic drugs include combination of antiplatelet and anticoagulant drugs. So we all know aspirin, which is a common antiplatelet drug, which acts on thromboxane A2 receptors. We're also familiar with clopidogrel and prasugrel anticoagulor, which basically acts on ADP P2Y12 receptors. And we also have some idea of the parenteral anti-ADP receptor blockers like cangrelor, and also the antiplatelet drugs which block platelet glycoprotein 2B3A receptors like abscesimab, tirofiban. Coming to the various anticoagulants drugs, so we have the oral drugs and we have the injectable drugs. So the commonly used oral drug is the vitamin K antagonist, like warfarin or acetrom. And then we have the newer oral anticoagulant agents like dabigatran, which acts on thrombin. And we have rivaroxaban, apixaban, edoxaban, and betrixaban, which acts on factor 10A. So of these factor 10A inhibitors, only rivaroxaban and apixaban is available in India. I don't think that the two are available. The injectable anticoagulant drugs, which act indirectly on thrombin, is heparin and low molecular weight heparin. And we have direct injectable antithrombin inhibitors like bivalirudin, hydrodin, and argatroban. These drugs are mainly used in heparin-induced thrombocytopenia. And we have a specific anti-10A inhibitors called fondaparinux, which again is used in heparin-induced thrombocytopenia. So coming to the newer agents, they are called DOACs, NOACs, or DOACs. So essentially, they are direct acting oral anticoagulant or non-vitamin K antagonists or newer oral anticoagulants or target-specific anticoagulant agents. So they basically act on thrombin or on 10A. So there's only one drug which acts on the thrombin, or which is a thrombin inhibitor, which is dabigatran, and the rest of the drugs is factor 10A inhibitors. So as we all know, prior to 2010, it was just warfarin, nothing else. But however, since 2010, there has been a flurry of drugs, which are called as newer agents, which acts on either factor 2 or factor 10A. So why was there a need for these newer anticoagulant agents? Essentially, this slide shows the uptake of the warfarin or azithromycin in various countries for atrial fibrillation. As you can see, the percentage of use of warfarin in a newly diagnosed AF in India is just about 40%. And there's a variety of reasons for this, which I'll come to in a couple of minutes. So this mainly, the problem with warfarin is that it has quite a lot of interaction with drugs and food. It has a very narrow therapeutic index, and it has a very unpredictable anticoagulant effects. And most important is the need for regular laboratory monitoring, which is a huge problem in India. And also, it's just not the monitoring; it's just the accuracy of the test just varies from lab to lab, and it's essentially not reliable. To overcome this, the DOACs were designed. They basically have a very rapid onset of action. There are very few drug interaction, and essentially they don't require routine anticoagulant monitoring. Just a quick slide about warfarin. We all know that it is a traditional choice for anticoagulation. It's basically a vitamin K antagonist. So we all know that factor 2, factor 7, factor 9, and 10 are vitamin K dependent factors. So essentially, these factors are depleted by warfarin, and that's hence the anticoagulant effect. So there are still a few conditions where warfarin is preferred over DOACs, which probably most of us are familiar with. The first one is if people are well established on warfarin, then probably you may argue that you could continue with them. So when we say it's well established, what we need is that time in treatment range should be at least 65% of the time. I think this is very difficult data to get in an Indian setting where the tests are done at different places, unlike in West where all the tests are centralized and you can automatically get the time period in range for a patient. It's very difficult in India. So I think to establish if somebody has been within the treatment range for about 65% of the time is quite difficult. And again, that's the major pitfall in our population to use this drug. Obviously, in prosthetic heart valve, warfarin is preferred. If cost is an issue, then warfarin can be used. However, the drugs have got, with the generic drugs, it is really, really cheap nowadays. Again, if there's significant renal impairment, warfarin can be considered. And some of the anti-epileptic drugs and anti-HIV drugs, and especially with the antiphospholipid antibody syndrome, DOACs are either contraindicated or it needs to be used with a great degree of caution. So now coming to the drug of today's discussion, rivaroxaban. So I'm just going to talk about its pharmacology. So we all know that it acts at factor 10A level, and the mechanism, the onset of action is quite quick. It acts within 2 to 3 hours of starting the drug. So this drug, this slide essentially summarizes the various pharmacological aspects of the various anticoagulants. So as you can see, the rivaroxaban, which is highlighted in red, is a direct 10A inhibitor. It has a very good oral bioavailability of close to 100%. Essentially, it is preferably taken with food, and it has a lesser degree of renal clearance, which means that it could be used in patients with impaired renal function. And the Tmax, or the onset of action, is just within 2 to 4 hours. The only important thing is to consider is that this could be a potential interaction with the drugs which either inhibit or induce cytochrome P450, 3A4 enzymes, or P-glycoprotein enzymes. The other advantage of rivaroxaban is you don't need to adjust the dose based on the age of the patient, so it can be used in older people. It can be used in extremes of weight. With abnormal hepatic function, if it's child few A, then no dose modification is required. However, if it's child few B and C, then it is contraindicated. Again, a certain dose modification should have to be done for creatinine clearance, as has been shown below. So now next, coming to the indications and the dosing. So this slide essentially shows the various indications, current indications for rivaroxaban. So it is used in conjunction with aspirin in acute coronary syndrome and in peripheral arterial disease. It is used for both prevention and treatment of venous thromboembolism, and is also used for prevention of stroke and embolism in non-valvular atrial fibrillation. This is a very busy slide, so it's basically for benefit of audience. If they want to go back and look at the presentation later, it just gives the various dose adjustments needed with various renal, with the differing creatinine clearance and for different indication. So what does various guidelines say? If you look at essentially with different guidelines, they all recommend using NOACs, including rivaroxaban for high CHADS2 VASc score, non-valvular atrial fibrillation. So what is the advantage of using rivaroxaban? So essentially, the relative risk reduction in stroke is about 80% with rivaroxaban, and it's about 90% with venous thromboembolism, and it's about 40% in patients with atherothrombosis. Now coming to some of the specific conditions where you may want to initiate anticoagulation. So especially if you want to initiate anticoagulation after a TIA or a stroke. So if it's a TIA, you could consider starting NOAC a day after the stroke. Probably you're all more familiar with this than myself. And if there's a persisting mild neurological defect, it can be started after 3 days. And if there is a moderate neurological impairment, it's better to exclude an hemorrhagic transformation before starting on a NOAC, and the recommended duration is 6 to 8 days. And if there's a severe neurological deficit, the recommended duration to start NOAC is after 2 weeks after the onset of the stroke. So the next specific condition is, I think we probably, most of us probably would be faced with this question as to when do we restart anticoagulation after an intracranial hemorrhage. So if a person has an intracranial hemorrhage, the first question we need to see is what are the risks and benefits of starting that oral anticoagulation? Is the risk recurrent? So if any of these factors are yes, then you should strongly think not starting anticoagulation, like if it's a severe intracranial bleed, if they have multiple cerebral microbleeds, or if there is no reversible or treatable cause for the bleeding, it's an older age group, or if there's uncontrolled hypertension, or if there's a history of chronic alcohol abuse, you should be extremely cautious if you do want to reinitiate the oral anticoagulation. Otherwise, they can be started after 4 to 8 weeks after the intracranial event. So next thing what we face is probably discontinuation of NOACs, mainly around the perioperative period. So basically, the half-life of all the NOACs is roughly around 10 to 12 hours. So the most of the drug is out of your system within about 12 hours. So essentially, for the most surgical procedures or the surgical procedures with a standard bleeding risk, just 1 day of stopping the drug is good enough. However, if it's a major surgical procedure, you may want to stop the drug about 2 to 3 days prior to the surgery. And sometimes if the patient is at the high risk of having a clot, then we may want to consider starting them on anticoagulation with heparin. Again, it's quite important to know that the renal function is okay. If the renal function is creatinine clearance is not good, then you may have to further increase the duration of stopping the drug. So when do you resume the therapy after the procedure? So if it's warfarin, generally you can start after a day of surgery, assuming there is well-controlled hemostasis. The rationale is because it takes about 2 to 3 days for warfarin to establish the therapeutic range. Most of the NOACs can be reinstated within 48 to 72 hours. And in a high-risk patient, as I said, you would want to consider a bridging therapy with unfractionated heparin or low molecular weight heparin. Now coming to the safety of NOACs, it's a very safe drug. This slide is essentially a summary slide which shows the pooled risk from various trials of newer oral anticoagulant agents. So essentially what it shows is that it is across the board, it is either superior or it's better than warfarin, or at least it's not non-inferior to warfarin in terms of ischemic stroke, hemorrhagic stroke, myocardial infarction, or all-cause mortality. Again, it has a better intracranial hemorrhage profile. Probably in patients with GI bleed, there's slightly increased risk in NOACs in comparison to warfarin. So this again slide it combines. It just shows the safety profile of rivaroxaban compared to warfarin. Essentially, what you can see, it's either similar to warfarin, or it's non-inferior, or on some occasions probably superior to warfarin. So why is there an underuse of anticoagulants? There's a lot of misconceptions about the thing with anticoagulants is either the people are afraid to start it, or once they've started it, they're afraid to stop it. So I think it works both ways. The main apprehension about starting the anticoagulant is that there's misconception about the benefits, or there's overestimation of the bleeding risk and underestimation of stroke risk and the fear of bleeding. This slide quite beautifully illustrates with the increasing chance to score, the stroke risk disproportionately increases in comparison to the bleeding risk. So when we start anticoagulation, any patient, it's quite important that we look at the Hasbled score, which constitutes hypertension, liver function, renal function, history of stroke, history of bleeding, age of the patient, and the drugs and the alcohol. It's quite important because there's quite a few of this are modifiable risk factors, and once you modify them, essentially it reduces the risk of patient having a bleed. Now coming to the switching and the timing of the drug. So if somebody's on warfarin, if you want to switch to rivaroxaban, you can just discontinue the warfarin and start rivaroxaban as soon as the INR is below 3. If somebody's on unfractionated heparin, if you want to stop the rivaroxaban, essentially you can stop the infusion and start rivaroxaban essentially at the same time, because the half-life of unfractionated heparin is just about 90 minutes. And if you want to switch from any other oral anticoagulant to rivaroxaban, you just have to start at the same time the next day prior to starting the anticoagulant, or at least a couple of hours before. So essentially, if somebody is on, say, dabigatran today, and you are planning to start him on rivaroxaban, so you can essentially start him at the same time tomorrow, or maybe an hour or two early. Coming to the adverse effects, essentially, it is a very safe drug with very minimal side effects. I haven't seen any major side effects in most of the patients whom I have used this drug, mainly in the context of venous thromboembolism. So this is the data from the Rocket AF study, which essentially shows the side effects of the adverse events noted in 7,000 odd patients were comparable. Obviously, we should just need to be mindful of the liver function tests, but other than that, I think it's a very, very safe drug. The next thing is, how do you manage bleeding? Obviously, so this you have to contact somebody who is probably familiar with the managing in the bleeding setting, preferably with hematologists. So I will just discuss about all the agents and how to manage them if there's bleeding. So essentially, the first important thing is when you notice the bleeding is to see whether the patient is hemodynamically stable or not. If there's any active bleeding site, you have to compress and see if you can mechanically stop the bleeding. And you also try and obtain the anticoagulation history. The most important is when was the last time the patient took the drug. So with if the patient is very clear with the history, especially with the NOACs, if he says that he's not taken the drug in the last 24 to 48 hours, and if your coagulation test is pristinely normal, it's highly unlikely that NOAC could be causing the bleeding, or at least contributing to the current episode. So if somebody is on warfarin, if he comes with bleeding, you could give him vitamin K. If there's severe bleeding, you should ideally give him what we call as prothrombin complex concentrate, which is recently become available in India, but it's very, very expensive. It almost costs a lakh. Otherwise, we can use fresh frozen plasma. With the NOACs, again, you use the symptomatic measures. You could use oral charcoal if they've recently ingested. And nowadays, specific antidotes are available, especially for dabigatran in India. We don't have antidotes for rivaroxaban yet in India, I believe. If none of these are available, again, you could consider using prothrombin complex concentrate or a FIBA, which is a factor VIII bypassing agents, which is used in hemophilia. So this slide again essentially summarizes what I told you. So if somebody's on warfarin, you give them PCC, which is prothrombin complex concentrate. If somebody has taken dabigatran, you can consider giving them idarucizumab, which actually most of the drug company will provide this drug. But I think the problem with the drug is getting the drug in time is a big challenge. The factor Xa inhibitor, there is Andexant, which is not available in India. Again, if it is not available, you have to consider giving PCC or FIBA. So this is just the comparison of pharmacokinetic agents of various reversal agents. The vitamin K reverses within 2 to 8 hours, probably about 6 hours. That is mainly because of the factor 7, which is the short half-life of 6 hours. So as soon as you give vitamin K, that is the first factor to be replenished. If you give FFP, it takes about 1 to 4 hours to work, which is why PCC is preferred in bleeding due to warfarin or citrome, because it works within 10 to 15 minutes. The other thing which you can use is recombinant 7A, also called NOVA7, which again is extremely expensive and it's quite difficult to get. This slide is a summary of various antidotes available. So the first one is idarucizumab, which is an antidote for dabigatran. It is there's a very high affinity for thrombin. The affinity is about 350 times higher than dabigatran. It just displaces the dabigatran and resulting in stemming the bleeding. The next one is Andexant, which is a factor Xa inhibitors, which is not available in India. And I personally don't have experience with this drug. And the other newer drug, which is an universal NOAC inhibitors, is Ariprazin, which again, I don't think is available in India. Next, coming to the drug interactions and contraindications. So essentially, it has a very good profile of interactions. You should be only cautious if you're using a drug which either inhibits or induces P-glycoprotein or cytochrome P450-3A4, like the azoles, like azoles like ketoconazole, itraconazole, if you're using them, or if the patient is on a retroviral drug like ritonavir, and if the patient is on macrolide antibiotics like clarithromycin, and some of the anti-epileptic drugs like carbamazepine and phenytoin, you have to be extremely cautious when you're using the NOACs. So now coming to the benefits, some of the benefits of NOACs over the other benefits of rivaroxaban or other anticoagulants. Broadly, I think in my view, most of them are of similar safety profile. However, there are certain conditions where you may prefer one over the other. So what is the advantage of rivaroxaban over warfarin? So essentially, it has a quicker onset of action. Elimination half-life is about 10 hours. It has stable pharmacokinetics. It has limited interaction with food and other medicines. And there is no need for regular blood tests, which is probably the most important aspect of this drug. So this leads to it's less labor intensive, reduced administrative cost. This is more actually in Western population compared to ours, where they have a centrally run anticoagulation system. So improved quality of life because it will be reduced number of visits for the patients to the hospital and to the laboratory to get their blood checked, and they have a improved and there's improved compliance because of this. Again, this improves the benefit of the drug. Coming to benefits of rivaroxaban over dabigatran, the main thing which I have this thing is dabigatran is mainly renally excreted, considering a substantial proportion of our patients are elderly with a degree of renal impairment. So this is you're slightly apprehensive about putting the patients on dabigatran, whereas with rivaroxaban, you could use with creatinine clearance down until 15 ml per minute. So in that sense, rivaroxaban is much better. And the other most important thing is rivaroxaban is just once daily as against dabigatran, which is used twice daily, thereby again increasing the compliance. Rivaroxaban over apixaban, again, not much to choose, both are equally effective, but the thing with apixaban is it's a twice daily regimen, and the cost is, the issue is the cost, it's quite expensive. So this slide just shows the importance of once daily regimen as against the twice daily dosing of NOACs. As you can see, there is better compliance with once a day drug than twice a day drug. And also there is a better risk reduction with stroke with once a day drug. This I've already touched upon. So what are the approved indications that is used in for the prevention of non-alveolar stroke, coronary artery disease, DVT for both prophylaxis and treatment, and then pulmonary embolism. This is another question which probably you come across more. Can we crush rivaroxaban? The answer to that is yes, it can be crushed. It can be mixed with water or puree, and it can be administered orally, or it can be administered to Ryle's tube or gastric tubes. So essentially, in that sense, it's a significant advantage. And one other the important thing is a question quite a few people ask is, can any of the laboratory tests be used to guide the therapy with any of the NOACs? The simple answer to that is no. So you can't estimate the amount of drug based on the PT and the APTT, which is the routinely used laboratory test, because there is no linear correlation between the values and the newer oral anticoagulants, unlike with the warfarin. So your PT, INR, and APTT cannot be used to guide therapy. However, if your PT with rivaroxaban, if your PT is entirely normal, then it's highly unlikely the drug is in the system. With dabigatran, if the APTT and the thrombin time is normal, it's highly unlikely that the drug is in the system. The thrombin time is especially very, very sensitive to dabigatran. And there are newer assays like anti-10A assays specifically, which can check the amount of rivaroxaban available in the blood. So this is not available in our hospital at St. John's, but there are a couple of labs which do this assay. So essentially, this test just summarizes. So if what is the usefulness of the test? Essentially, thrombin time, APTT, and PT is not very helpful. It basically just tells you whether the drug is there or not. It doesn't tell the amount of the drug present in the blood. This is again the same slide, which just shows the various clotting parameters affected by warfarin, dabigatran, and the factor 10A. As you can see, the PT is mainly affected by the rivaroxaban, and the APTT is affected by dabigatran. Now, just coming towards the end of my presentation, there are a few trials which, because of which these drugs were approved by the FDA and the various European agencies. This is the number of trials like Rocket, Relight trial, Engage trial, Aristotle. Across the board, it showed that NOACs were preferred in terms of efficacy and safety, and also in reducing mortality. Finally, just to summarize, so rivaroxaban is a direct factor anti-10A inhibitor. It has a predictable dose-dependent activity, so it does not actually require any routine coagulation test monitoring. It has a rapid onset of action, and it has an advantage of just being administered once daily. And it has proven in various trials, it has a better efficacy and safety profile, or at least non-inferior to the warfarin. It is used in various, it has used in various indications like coronary artery disease, acute coronary syndrome, ventricular thromboembolism, both for treatment and prevention. That's the end of my presentation, and I'm happy to take any questions if you have